Okay, is that all right? Good. Thank you very much. My name is Susannah Stanway. I'm a medical oncologist with an honorary position in the Royal Marsden Hospital in the UK. And I'd like to talk a little bit about survivorship challenges in low and middle income countries. I'd like to thank Dr. Mustafa Sumon for the invitation. I'd like to thank Professor Saiful Haq and the Three Musketeers for inviting me and really for showing us that every single one of us in the room can act as a catalyst for change. This conference has been absolutely fantastic. I think the standouts for me have been just the sheer numbers of people here, the engagement with the younger generation and the young investigators, and engagement with people in power, and certainly our trip to see Professor Mohammed Yunus and his endorsement and engagement with the Lancet series of improving cancer care in SARC countries was amazing. So thank you very much. So I'm going to divide my talk into 4 parts. I'll try and speak quickly because I know that we're time challenged. My talk's really aimed at the younger generation of people here. I'm going to talk a little bit about the statistics of global cancer, why we need to improve cancer care so that we have more survivors of cancer, and care for those living with and beyond cancer, and then just a summary slide at the end. So global cancer statistics, which I'm sure most people in this audience already know. Cancer is currently responsible for 1 in 6 deaths globally, 17 million new cases a year, 9.6 million deaths from cancer globally, and the majority of these deaths happen in low and middle income countries. By 2030, this will be 75%. And increasing incidence is outpacing improvements in cancer survival. So of the world's 8 billion people, if you look at this infographic here, you can see that the majority of the world's population, or the largest bulk, live in Asia. And so it's not surprising that looking at incidence, mortality and prevalence, the highest number are in countries in Asia. And indeed, as we know, the SARC countries represent 24% of the global population. So looking here at data from IARC, from the GloboCan website, you can see on the left cancer incidence in women, and you can see that the most commonly diagnosed cancer in pink is breast cancer, with only a few countries where cervical cancer is the leading cancer diagnosed. And on the right, you can see mortality data with the blue countries, lung cancer, pink is breast cancer, again, orange, cervical cancer. So globally, 1.7 million cases per year of breast cancer. Every year, 600,000 people globally die of breast cancer. That's 1 person every minute. So a little bit of my talk is going to be through the lens of breast cancer, because that's what I've specialized in for the last 10 to 20 years. And 6.9 million women living globally within 5 years of a diagnosis of breast cancer. Within the US, this is around 4 million people living beyond a diagnosis of breast cancer, for example. And we can see here on bottom left the Global Breast Cancer Initiative Implementation Framework and its 3 pillars that are really aiming to improve that. So it's one of the 3 cancers that they're focusing on, the others being cervical cancer and childhood cancers. So this is cancer incidence, mortality, and survivors diagnosed within the last 5 years. The top 5 cancer sites, you can see here that both sexes combined. Lung cancer is number 1, breast cancer is the second most common cancer, the 5th leading cause of cancer death. And with respect to the cancer survivors, the biggest single group are those people living with and beyond a diagnosis of breast cancer. So just taking 1 step back, how are we going to increase the numbers of people surviving cancer? Well, I think number 1 has got to be political will. I teach at 3 universities in the UK, and I usually, when I'm speaking to juniors, start off with this letter to the New England Journal of Medicine, because I think it lays out really important, salient features. So this is called Moonshot to Malawi, and it was published in the New England Journal of Medicine in 2016, and it was off the back of President Obama's State of the Union address in 2016. And it was written by Satish Gopal, who is now head of the Center for Global Health at the National Cancer Institute in the US. And he was talking about the huge amounts of money that's going into cancer in the US, the sort of dizzying heights, all these new drugs that are being developed, the improvements in cancer, in times to cancer drug approvals. And he was saying that I live in Malawi at the moment, a country in sub-Saharan Africa, 17 million population, and I'm not seeing these embarrassment of riches that you're describing. Most of the women that come to me with breast cancer have had symptoms for over a year, and they don't have a conceptual understanding of what breast cancer even is. And then he went on to say that what ultimately transformed HIV from, in sub-Saharan Africa from an existential threat to a prototypical global health success story was broad civil society activation and political will. And he finished by saying that shooting for the moon is important, but so is shooting for a world that's just and equitable. So I think that when we're thinking about where cancer and NCD sit within the broader sort of global security architecture, I think that these sort of Venn diagrams are quite interesting. So the Collins word of the year in 2022 was permacrisis. And if you look at the news today, it seems to think that it makes you think that we're lurching from crisis to crisis. And so I think that it's important that we have resilience of our health systems put into our cancer control plans. We've got pandemics, and we've seen the terrible effect that the COVID-19 pandemic has had on exposing the fragility of our health systems and worsening cancer outcomes. At the top, we see conflict. 2 billion people in the world live in countries affected by conflict. And this not only increases carcinogens, which cause cancer, but also severely disrupts ability for us to give cancer care. We've got disruptions to Earth systems governance, of which climate change is probably the most talked about. And as I mentioned in my talk 2 days ago, this not only increases the cancers such as pollution, increasing lung cancer, but also fragments our systems, and with things like extreme weather, really disrupts our ability to give cancer care. And then at the bottom, we've got artificial intelligence and the broader tech architecture, which, yes, has got the ability to really improve how we deliver cancer care, and I'm hugely excited to hear Cupid's talk this afternoon, but also does have potentially nefarious components, and I think we've got to consider the damage that misinformation, malinformation, disinformation can have on science and the broader population. And then thinking about other things, the markets, the economy, the huge global debt that we have at the moment, which is challenging the fiscal headspace that countries have to deliver publicly financed healthcare. And I think really now more than ever, we need excellent leadership with measured, sensible people acting on evidence to improve cancer outcomes. So I think we can all agree that rich people in any of our countries are going to be able to access good cancer care, be it India, Sri Lanka, here in Bangladesh, the UK. But really, we're talking about standing up for the unheard people and the have-nots in society. So yes, we want to have equality, but we really want to focus on equity. So health equities are unnecessary, avoidable, unfair, unjust differences between the health or healthcare of one person and another. And really, this kind of situation that we see, where 70% of the world's wealth is concentrated in the top 10% of the world's population, has to be readdressed, because we know that inequality is not only bad for health, but it's bad for democracy, for social justice, for human rights, and for social cohesion. So yes, we need to have adequate investment and political will, but we don't need to have necessarily huge monies poured into cancer care, as we can see here. So the US, for example, spends 3 times what Italy spends on cancer care, but has the same cancer mortality rate. So we need to embed cancer care within the Sustainable Development Goals, 17 of them, 169 targets. So I think SDG 3 is probably the most pertinent. Ideally, we want to have universal health coverage, but as you can see from this tracking UHC 2023 Global Monitoring Report, this is not going well. But also, another one of the number 3 goals is to reduce the premature deaths from non-communicable diseases by a third by 2030. But really, cancer care fits into every single one of these 17 SDGs. This is an all-of-government problem, an all-of-society problem, and we all need to engage with it. What we need is top-down approaches from multilateral institutions such as the UN, but we also need bottom-up approaches, and I think that organisations such as City Cancer Challenge, which are really looking at how engagement at the city level, on the ground, grassroots, can really make a difference and are showing brilliant results. We need to consider the whole cancer continuum. The focus needs to be on prevention. No country is going to be able to afford to treat its way out of cancer. And this talk is about survivorship. I think in parallel with improving cancer outcomes, we must make sure that those living with and beyond cancer live good quality lives. And I'm really pleased to hear the plethora of talks at this meeting on exactly that. We need to create survivors who can then act as advocates because we know the power of advocacy. We need cancer intelligence, and it's great to see from the SARC series that all of the SARC countries are working on their cancer registries, and that all of them have national cancer control plans then they must be adequately funded. Focus on prevention, as I've just said, and focus on early presentation and timely diagnosis. So you can see here on the right an infographic from Cancer Research UK, one of our leading cancer charities in the UK, just showing the worst outcomes. This is in the UK, if you're diagnosed with one of the 4 most commonly diagnosed cancers at an early stage. On the left, your chances of surviving for 5 years in blue, versus on the right if you present with late stage. And we must contextualize how we manage cancer. So this is the first WHO Traditional Medicine Global Summit that was held, I think, the year before last, which I think is super important. We know the value of Ayurvedic medicine in India, for example, of traditional Chinese medicine, of traditional medicine in Africa, and we have to acknowledge this and make sure that we have evidence supporting it where it's used. I don't think cancer care should be siloed, but we must make sure it's addressed as an entity. And I think that initiatives such as this, such as of my friend Pavna Sarowi, who I visited recently in Raipur, she showed me her fabulous mobile cancer detection van, which also addresses other NCDs, such as doing blood sugars, measuring blood pressure, and doing pap smears. And it's very similar to the MAN van that has come out of my hospital, which goes into disadvantaged communities in London, doing very similar thing. And we must address capacity and capability issues with respect to the manpower. There's a global manpower challenge. It was great to see the third Lancet paper looking specifically at this in education. And we must build capacity with collaborations. We must avoid the brain drain, make sure that the WHO Code of Practice regarding recruitment is adhered to, use the workforce we have, and use innovative technology. And these 2 papers that are quoted in Professor Huck's paper really show how education can be used to improve this. And really, it's education that's doubled life expectancy in the 20th century. This is just to highlight what one of my mentees from Somaliland, for example, who won the Keyshow Best Abstract last week, I'm really pleased about. You know, in Somaliland, they don't have a cancer registry, but he's been doing fabulous work just collecting data on the patients in his hospital. And I think that we all have to start somewhere. Priorities for cancer research in low and middle income countries. This is a great review that was led by C.S. Pramesh at Tata Memorial in Mumbai. And really, the research has got to be shown how we can reduce the burden of advanced stage presentations, to improve access, affordability, and outcomes in cancer care via solution-orientated research with a focus on implementation science, leveraging technology, and good health financing. We've heard lots in the preceding session about the importance of de-escalation, and I think when it comes to survivorship, this is also really important, but we've got to have the evidence to back this up. So studies such as the START study, looking at hypofractionation in the adjuvant setting of breast cancer, which was led by my old boss, John Yarnold, at the Marsden, and studies such as this low-dose immunotherapy study of nivolumab and head and neck cancer. And I really think that this region is leading on this. I mean, this study was done in India, and the use of biosimilars and this treatment de-escalation work is really being led so well by this region. So what about care for living with and beyond cancer? So I'd like to highlight this letter that was written to The Lancet by the amazing Namala Bupati, who works in Malaysia. And she said that cancer control efforts are focused on improving detection and access to cancer treatment. But there needs to be more emphasis on supportive care and survivorship care. Must address the unmet needs and measure patient-centered outcomes to guide policymakers, hospital administrators, and beyond as to what to prioritize. And the success of cancer control efforts should be pivoted from focusing not just on overall survival and clinical outcomes, but to patient-centered outcomes and unmet needs. And I think that these 5 shifts in care and support for people living with and beyond cancer that were published some time ago by Mike Richards in the UK are really important. There is this cultural shift with a greater focus on recovery, health and well-being after cancer treatment, a greater focus on personalised care, on self-management, and a shift from a single model of follow-up to tailored support and measuring experience and outcomes. And this sort of infographic by the Health Foundation about person-centred care, I think, is really important. We must make sure that our care is personalised, coordinated and enabling, and shift from what matters what matters, what is the matter with you, to what matters to you. So the response at my hospital to the follow-up of breast cancer has been something called open access follow-up. And this really comes off the back of the lack of evidence of doing serial scans and examinations in people following early breast cancer. And it really focuses on empowering and educating patients who have had breast cancer and to enable them to move on and to give them better access when they do need to see us in clinic, but without compromising ability to diagnose recurrence. And so what's going to be needed in this survivorship initiative? Well, it's going to need all of us, and it's going to need education, research, capacity building of relevant services, allyship, convening, networking, mentoring, and advocacy. We need to advocate for the fact that survivorship care is necessary. And this supportive care after curative treatment for breast cancer, resource allocation in low and middle income countries paper is really good. And it sort of resource stratifies what you can do for various survivorship challenges. And then papers like this advocating for the need for more research and more evidence to be generated in Latin America, I think are really important. And workshops such as this that happened in the US involving people in low and middle income countries as well, addressing what needs are, improving workforce capacity, leveraging partnerships, prioritizing funding, policy strategies, etc. will be so important. I think that we all need to have adequate frameworks in place. So this is the framework that we have in the UK that came from, that was led by work by Macmillan called the Recovery Package, and it focuses on holistic needs assessment and then resulting care planning, which also involves primary care. And this is going to involve a multidisciplinary workforce and is going to be multi-domain. So it needs to assess physical complications and challenges, social and psychological effects, spiritual effects, and also health promotion. Because when one has a life-threatening illness, this offers an opportunity for people to really consider their lifestyle. And so it's an opportunity for health promotion because, as we all know, money spent on medical care is only a small fraction of what makes a difference to health, and actually individual behaviours and environments in which people live make a much bigger difference. I think we need more studies like this, which look at just not the need for survivorship care and why we need to be addressing people's challenges after a diagnosis of cancer, but also showing that if we don't, cancer outcomes are worse. So we know that non-adherence, for example, to endocrine therapy leads to worse outcomes in breast cancer. So how can we help people adhere to treatment such that their breast cancer outcome is better as well as their quality of life being better? This is a study that was done by my unit looking at ongoing needs. This was led by Alistair Ring and 625 survivors of breast cancer. And we need to do more studies like this in our own individual settings so that we can then devise the pathways and the services that are required. That study we then replicated with colleagues Nazima Darcy in Tanzania and Beatrice Adai in Ghana. And we did a similar study looking at what the needs were following breast cancer diagnosis in patients in their settings, which helped them then to upskill their allied health professionals and medical staff and devise pathways in their settings. So we need to have guidelines. There was a really great interactive session on guidelines yesterday. Yes, I think that there does need to be adaptation of guidelines that are led by high-income countries. And NCCN has done work on this, but I think that these need to be further refined for our individual settings. We need to have education, both for patients, people who have had cancer and their carers and loved ones, and also for people caring for these patients. So this is an example of an educational tool that's free to access from Stanford University, which helps educate people in primary care about survivorship issues following a cancer diagnosis. This is another study that we did as part of the London Cancer Alliance, which I was part of. So the London Cancer Alliance looks after over 5 million people. And we looked at what the needs were of our healthcare professionals and which areas of survivorship care they needed help with because they didn't know enough about how to manage. And I think that this kind of work needs to be done in all of our settings as well. And then we need upskilling about particular aspects of survivorship care. So I'd just like to highlight the Global Cardio-Oncology Summit, which will be held next year in Cape Town, and the European Society of Cardiology guidelines around cardio-oncology, which again is free to access. There's an associated app, which is really good and really helpful. I think that educating in primary care and in the community settings is important because these are the people that are going to be seeing cancer survivors. And this is a study that we published in The Lancet, which looked at 100,000 survivors of cancer, nearly 500,000 matched controls, and showed that survivors of most site-specific cancers have got increased medium to long-term risk of cardiovascular disease. Contextualization I've already touched upon. And these are examples of research methods, workshops that we have run and collaborated with people on the ground in Nepal and in India in the last year. So I'd just like to finish by saying that for cancer control, we need to create survivors. And this is going to involve harnessing political will, cancer preparedness, focus on prevention, focus on early presentation, timely diagnosis and treatment, ideally sitting within universal health coverage, with a stress on system strengthening sitting within the SDGs. And with respect to living with and beyond cancer, there are broad shifts in healthcare implementation. This is going to require advocacy, frameworks, education, research, guidelines, and capacity building. Shooting for the moon is important, but so is shooting for a world that's just and equitable. Thank you for listening.